have an understanding of who's in the room, and we're incredibly grateful for all of you. And again, it's as is obvious in my enthusiasm and trying to disseminate things. And in this slide, we are addressing incredibly long planned for domains on the community level of food access, neighborhood safety, and access to green space in this fall cycle. Super excited. Oh, Jacqueline, hello. I haven't seen you in a bit. Hello. There's like all of these colleagues I haven't seen in a little bit. It's nice to see you again.
Hi, Sarah. I'm glad to be here.
I know. It's good to see you. All right. Oh, welcome. It's so good to see so many friends from across the ecosystem, new friends, names I recognize, even if I haven't met you before. Sue. I recognize Sue. Sue, it's good to see you, friend. All right, we'll be starting ever so shortly. And again, thank you so much for joining this critical work. As you can tell, I guess we're going to kick off right now. It's 3 minutes after the top of the hour. We try as much as possible, and you'll hear more about this, to integrate the chat and all of your voices as we go throughout the meeting today. So please, consider this a seminar more than a lecture, right? We create the knowledge and the perspectives together, and all your voices are critical. All right, here we go. Welcome to the kickoff of the fall domains. More subject matter expertise information to come. This is the highest level at this time, but welcome, and next slide. Thanks all for joining. Everyone, this is like partly what I was speaking to. Everyone's muted upon entry, but there's lots of opportunities for conversation throughout. We even took the intention of sending out some accessible white papers on the topics that we will be addressing this fall, because we wanted to make sure everyone understood and had an opportunity to read. We didn't want to overwhelm you. The homework is not required, but like a small view in the depth of literature we've been reading and collating and gathering and analyzing to prep for these domains. All calls are recorded. Recordings are available on the Confluence, on the Gravity page following. When it comes to looking at resources, and you'll see this, there's a lot of high-level all-domain resources that really talk about the importance of built environment and resilient communities and community intention. Those are going to be in every single Confluence page, especially some of the highest level federal documents or Urban Institute analyses. You'll see them on every single page. Asha, the amazing Asha and Sarah Bahal are curating those spaces on a daily basis, but you'll also see very specific domain level of resources there. And all of the meeting recordings are available in the meeting section of the Confluence for after the call. As I mentioned, everyone's encouraged to actively participate. We welcome your voices. You're all community members. You live in places. You are experts in being in community and shaping good community, even if you're not a specific expert in this domain. And we really hope that you'll be part of the conversation. Please send all chats to everybody. As you can see, I read everything in the chat out loud. So if something's sent to me, I will likely read it out loud, because I don't, I have a hard time discerning in the facilitation work, but just send chats to everybody so we can collectively have a good conversation about the work ahead. Next slide. This next slide is a requirement as part of our work in open consensus standards development. We are required by being an HL7 accelerator to follow ANSI and trust practices guidelines. Every single person participating in the call has the responsibility to comply fully with federal state antitrust laws. The second individual speaking or providing written communication shall refrain from any discussion which may provide the basis for an inference that they have agreed to take any action related to prices, services, production, and allocation of markets, or any other matter having a market effect. So we don't discuss pricing here or other pricing or any terms that affect pricing. This is not the forum for that. And we apply these guidelines pretty liberally. So anything, even if it's not direct, but it could be construed as a violation, we just ask that it not occur. This is the only time I'm going to read this thoroughly, but it's important for a kickoff. And Oh, yes, Julian. Hi, Julian. Just know that this is part of the background for and guidelines for our work. Next slide. All right, here's the agenda. So, welcome and announcements. And then because this is a kickoff, we always start with a what is the Gravity Project overview. And then we're going to go through the topics and goals for fall 2025, kind of a how we got here this far along into our work. Every domain that we are addressing has history, right? We either carved it out from a previous domain or elevated it in a previous domain or worked with friends and colleagues for a long time to get here. So we'll kind of set that stage in the fall 2025 topics and goals. And then we're going to go into that high level, really like the evidence, the what and the why kickoff. We may have some subject matter experts on the call. Again, the public, there, we focus our SME expertise within those weekly hour-long huddles. Subject matter experts are welcome in the call. We welcome them all to talk if they want to, but they also can just observe and listen. But you will hear Asha and I going through the literature and how we got here for food access, neighborhood safety, and access to green space. And then we'll be integrating subject matter expert wisdom ever deeper as we go forward. And then because it seems so relevant, we have a little section just talking about kind of through points between the protective factor domains and stress domains and social connection domains we've made in the past, and how we see these themes of belonging and community and culture integrated into the evidence and domain criteria of the three domains that we're addressing this fall. We'll explain more of that, but we figured we'd be remiss if we didn't highlight those themes because many of you all were just with us in the protective factors and strengths-based work just this spring, and you'll see a lot of those concepts and themes coming to bear here in this work. And we'll talk specifically about some intersections with other domains as well. And then we'll close with community homework and next steps. We're super excited. All right, next slide. Next slide. So announcements, this is our standard page. So we invite one and all to the technical works. This is the terminology workstream. We'll go more into the structure of the project in a second in the gravity overview, but we really invite everybody to the technical workstream, which is our sister workstream. So we're terminology, and then the technical workstream focuses on this SDOH, social terms of health, clinical care implementation guide. That is the fire implementation guide for our work. They meet every other Wednesdays from 1 to 2, and it's a really fascinating meeting where we're talking about new use cases and resources, again, to deepen our ability to represent the uniqueness of social care and social care data exchange. So please come. It was just yesterday. It'll be again in 2 weeks. And we're focusing on brand new use cases and perspectives and requirements as we work toward our next version of the guide, which would be version 3. Believe it or not, we've been around for a while. The next meeting of the implementation work stream it's now quarterly. It is on August 28th, and we'll continue our conversation on applying gravity standards towards return on investment elements, right? Whether it be outcomes, savings, all the different possibilities that we have in ROI. That was our focus for 2025. So you can join us there. The focus there is on New York applications, specifically aligned with our partnership with the New York Department of Health to integrate gravity standards into the 1115 waiver that kicked off in January. So that's the focus of the August 28th meeting there. We are going to be, of course, at the HL7 working group meeting, really focusing deeply on some of the effects of doing the work that we do. So bringing to the working group meeting what it means to address protective factors and strengths within fire standards and kind of the requirements and uniqueness of that. We'll be talking about some of the 3.0 use cases we're working in the technical work stream, and briefly bring up some of the new things we've been doing, like the program classification work we did within our enhancements, that classification of social care programs for the purposes of navigation and a connection to services. So that was a spring. It was really all of 2024 and spring of 2025 initiatives. So all that is going to be addressed at the working group meeting. And then you'll also see us in multiple sessions at the Civitas annual conference in Anaheim. One specific gravity session, but also a couple others just about gravity. One of them from New York, right? So there's a lot of fun things happening at the Civitas conference. So a lot of things happening in the ecosystem. For anyone who's in this world, you know that September and October are conference months. So this is just a small view of the many conferences that are happening, and we look forward to hopefully seeing all of our friends there at the different sessions and conferences in the ecosystem. Next slide. All right. Any questions on the announcements? Okay. Next slide. All right. So what is Gravity Project? This is the overview. What's happening next with that workstream on program enrollment? Oh, Julian, it's ongoing. They do have a whole schedule of topics in the enrolled in program use case in the technical work stream. That calendar is posted. It is not finalized, but those Wednesday 1 to 2 meetings are where that gets addressed. Happy to loop you in. Sound good? And just note to support, Julia's talking about standards to document enrollment in program. Right. So believe it or not, even though we have med lists and we have care team members, we haven't had a standard for documenting the critical programs we connect individuals to in the name of whole person health. And so part of that is supported by terminology, like Gravity's creating the terms for the program. SNAP, WIC, right? Home delivered meals, right? And then that gets integrated for the purposes of interoperability with resources we're working within the technical work stream. So again, it's kind of remarkable. We're a primary care provider that I don't have a program list for my patients. This is just one of those things that comes up, right? In our work as we try to represent the complex and holistic nature of humans in the Gravity Project initiative, which relates to our vision. Julie, I hope that answered your question. You can see me trying to integrate the chat as I go. The vision, what is the Gravity Project vision? First of all, we are representative and sustainable. We imagine ourselves as a representative and sustainable consensus community, and that includes all of you that are collectively driving social care data standards to support the goals of population health and health equity. Oh, look, fantastic. My friend Corey is here. If technical is the sister work stream, then Corey is my brother from another mother. So Corey Smith is the technical director. And so he's answering your question there, Jillian. So we're a representative and sustainable consensus community that's collectively driving social care data standards to support the goals of population health and health equity, right? And I'm just centering in again at those final goals. Population health is really not possible without community level interventions, right? This is where this all comes down the pike, right? We can't take care of populations with person level interventions only. We don't move the data, right? So this is partly how we get here. And you can see the evidence for this across, all kinds of HHS relative initiatives over the course of many decades. So onward. Next slide. So the lexicon, this is important. We will present this a couple times and then just kind of it becomes what's known. So health equity is the state in which everyone has a fair and just opportunity to attain their highest level of health. It's built off of foundational concepts in, public health and health outcomes like Amartya Sen and the capability model, right? So it's really about opportunity to attain your highest level of health. Social determinants of health are the conditions in which people are born, grow, live, work, and age, importantly shaped by the distribution of money, power, and resources, and therefore fundamentally affected by policy. And this again ties into our fall domains, right? So community interventions are policy interventions, right? They're community actions. They are structural in design and intent. Great. And Lucy's a member, so you helped shape the vision. So grateful. Hi, Lucy. Always brilliant. Always happy to have you here, friend. Social determinants of health, importantly, can offer both positive and negative forces. And I am so grateful to say that we finally leaned into this. And Patricia, you commented, we can't address, we knew forever that we could not address holistic health within social determinants of health frameworks without addressing strengths, right? And protective factors, right? We're not just the sum of our risk. So very honored and excited that we did that this spring, thoughtfully. And I'm just, it was likely an area that we will develop and refine over time, but a really good base. So protective factors are the characteristics or strengths of individuals, families, communities, or societies that act to mitigate risk and promote positive well-being and healthy development. Social risk, and then the negative forces, we divide into two different elements. This is aligned with a paper written by one of our founders, Laura Gottlieb and Hugh Alderwick, which is called Meanings and Misunderstandings, right? So social risks are the adverse social conditions associated with poor health, like the pangs that come up from screening, right? And social needs or patient prioritized social risks. We are thinking of refining this slide because the term health-related social needs is used a lot, but it is structurally and conceptually equivalent to social risks, even if it has the word needs, because it's used within like CMS resources as the positive findings from screening, not necessarily that patient prioritized element. So just want to note we should have we're coming with a revision of this that will put HRSN and social risk as equivalent. All right, next slide. Again, we're touching on this for today, and then we'll likely sunset those slides because the kickoff will have happened. So incredibly grateful for our sponsors, members, and partners. We are an HL7 Fire Accelerator, which means we are driven by member sponsors. We couldn't do it without our members and our sponsors. So incredibly grateful for all of the individuals and entities on this slide. We are unique. We're the only accelerator that has this designated membership model because we do work from a social justice framework. We know that community-based organizations and patients are critical to representing and building good standards. We know they cannot afford the membership model, so we built this designated membership to support their voice within our governance. Again, incredibly thankful to all of our members. Many of these individuals have been with us since the very, very beginning. So grateful for them. Next slide. Our 3 work streams, as I mentioned, so Gravity has 3 different work streams. Terminology is what in the meeting you all are in. Our primary job is to create the language to name and address social needs. So we do that by convening here together, identifying with subject matter expert what subject matter experts what needs to be said, submitting concepts to terminologies, and then curating value sets. We'll talk more about that in a couple of minutes. And then those value sets intersect with the technical work stream, which is the development of the implementation guide, that beautiful fire implementation guide that is now in its 3rd version of development. That all happens in the technical work stream meeting. And then the implementation meeting is where we implement our standards, evaluate, refine, and bring that information back into our 2 work streams. The two base work streams of terminology and tech. And again, my friend Corey Smith is on the call. He guides the technical work stream as the technical director. Next slide. All right, so Gravity Project timeline. We were conceived in the mind of an international gathering at an expo but really a tiny expo in 2017. I had the honor of helping write that white paper that grounded that gathering with my friend at UCSF Siren. And then we kicked off in food insecurity in 2019, and then now have been going strong for 6 years almost. Crazy, 6 years, yes. And 6.5. Addressing many domains, all prioritized by our membership. And then along the bottom, you can see references in policy, and now that working on the 3rd version of the implementation guide. So top is terminology, domain development, value set development, and then bottom is policy and the IG development. A lot of work, and we're still going. Next slide. This is our 2025 roadmap. Again, so we're focusing on food access, neighborhood safety, and access to green space this fall. We're completing our enhancements to our program work that we started again in 2024. And then we're working on the next version of the implementation guide. And then we are doing our Hi, Lucy. Yes, and then we're working on an infinity group, yes, as well. Lucy Johns. Any thoughts, friend?
Yeah, thank you, Sarah. Could you go back to the previous slide for a second?
Yeah.
Yeah, this is beyond impressive. And I was wondering to make it even more informative and complicated, whether you could consider Chiron at the bottom, which
Okay.
shows in, I don't know, bold or a different type, something.
To interpret it.
Adoption
Mhm.
of
Yeah.
gravity standards
Mhm.
by who, Loink and SNOMED, and that really has elevated. I mean, this conversation all these years has been incredibly important to all the participants and everyone we know. But what really legitimizes
Mhm.
and enables uptake of what we do is adoption of our codes by those official entities.
I feel
So,
like I think you're right. I think it confused, like, you know how I said policy, drivers, and the ID are all on the bottom? It probably is smart just to have a timeline of key regulatory pings, like integration into USCDI V2,
yeah,
grounding in the HEDIS, NZQA, SNS measures,
terrific.
reference
Yes,
in, CMS dual special needs regulation,
exactly.
supporting SDOH. Yeah, exactly. I hear you, and that would be easy enough to create. And I'm actually doing that for the members for Monday, the timeline for that, apropos of nothing. So that's very easy and it makes sense. Hi,
Great.
Candice.
We see the previous slide to this one because that does touch on some of it, right?
Let me see. Oh, maybe. I don't think this one does.
Doesn't have the dates, but it has SNOMED. I mean, this is what's impressive, and I do mention
yeah.
like what Lucy just mentioned, like she said, it legitimizes it. But
Yeah.
yeah,
Well, the
anyway.
truth is, I'm going to push it back to you. You all legitimize it because our work as an HL7 accelerator, following those methods, are what allows uptick into those terminology stewards, right? So
Right.
this process as an accelerator and the formality of it and the consistency of it and the intentionality of it, right? It is what allows us that relationship to the standards, to LOINC, to SNOMED, to ICD. Because of that process, because of you all, we have special access, right? And so I think I have a path forward. I'll present it back at the next meeting and you guys can tell me if it works. Sound good?
Yeah, I didn't use the word legitimize deliberately. I said uptake.
Yeah. So I
Everything
think
we do is the
you're,
most legitimate thing going on in this sector right now, as far as I'm concerned.
Yeah.
But I'm talking about uptake. So
okay.
Yeah.
thank you.
And
And
action.
by year.
Love it. Okay. Looking forward to your wisdom and helping us refine things. We even refine our materials to via consensus. So go team. All right. I think we're good. Next slide. All right, and so we couldn't do anything that we're doing right now without a set of robust principles. We worked to develop them when we were first kicking off. They're available on the Confluence. They ground everything that we do. They are improving personal health outcomes, improving population health equity, ensuring personal control, designing appropriate solutions, ensuring accountability, and preventing, reducing, and remediating harm. They guide both the development of our concepts, and we apply them when we're developing terminology, and we apply them when we're doing, creating resources and solutions within our technical work stream, the implementation guide, and they certainly guide implementation. So incredibly grateful for our members coming together and you all helping to create these principles so early in our work. Next slide. Any questions? All right, ready to get into the meat of it. Okay, fall 2025 terminology, topics, and goals. I am going to just cover some high-level concepts here, and then we'll get into the actual domain kickoff, which is really just a general level setting as we think about the work we have ahead of us. And then I'm going to take food access, former farmer girl, And then I'm going to pass the mic to my lovely and brilliant friend, Asha Manuel, to walk through the other domains of reference. Again, if any subject matter expert is on the call, please feel free to weigh in, including patient expertise. Like, we really want to make sure that we create a conversation as we go forward. Next slide. All right, next slide. So it's really important to know that even as we are a member-driven organization and sponsors make the Gravity work possible, we do have a special relationship over the course of the 2024 through 2027. Gravity Project and Loink Health Data Standards at Registry, we are partnering over the course of 4 years to make significant advances in social risk terminology by addressing member prioritized social risk domains, as we're doing here, and ensuring completion of prior domain terminology submissions. We do that ongoing and consistently. As much as we're doing this new domain work, we are always working on submitting new concepts to SNOMED, ICD, Loink. We have a presentation coming up at the September IC10CM Coordination and Maintenance Committee meeting. Just noting that submission piece is huge, and we were just talking about that. Support for our collaboration comes from the Registry Foundation. We do want to note, as we talk about with any grant opportunity, that the views expressed within this effort do not necessarily reflect the views of the foundation, but I'm incredibly grateful for this partnership and the stability and focus it's allowed within terminology development over the course of these years. Next slide. What we do within this work, we develop data standards to represent and exchange patient-level social data documented across core activities of screening and use of standardized assessment. We separate these because some of our instruments that we find and utilize and center within our work are clearly not intended for screening. Like, for instance, we just are working on a new adaptation of the USDA food security model validated by our friends at Children's Health Watch. They do not talk about it as a screening instrument because it's not used for that pinging. It's used for a complex and robust assessment of the dimensions of food insecurity for households with children. And then we also develop concepts to represent either the social risk or the protective factor. We develop concepts to represent patient-centered and person-centered and community-centered goals. I have my community-centered lens here. We develop concepts to represent the things that we do, interventions and treatments. And you saw a lot of these policy interventions and treatments within those white papers we sent out in advance of this call. And we also developed terminology to represent outcomes. And I just put this here because woven throughout is the capacity to evaluate outcomes. We see it in the difference between high risk and lower risk, food insecurity, like homelessness concepts. We see it woven throughout everything that we do. So we wanted to pull that forward because it is a critical activity that we think about. Uses are manifold. Patient care, population care, care coordination, public health, risk assessment, value-based payment, clinical research, you name it. The concepts that we developed together have many applications, and pretty much you name it. Our domains of reference this fall are food access, neighborhood safety, and access to green space, as noted. And our domains in general, even though we're kind of outgrowing it, is the foundational early a NASEM paper capturing social and behavioral domains and electronic health records. Really outgrowing it only because of the rate in which we've been able to work and the robustness which we've been able to perform that work. So we have developed many concepts that were thought to be future state, way future state at the time of that paper. Next slide. All right, and then this is what we all do together. This is part of the secret sauce for Gravity. So I've been talking with a number of colleagues in the ecosystem, both in the standards development ecosystem and otherwise, about what it's like to lean into a space where there's such an absence of concepts, right? So Gravity is unique, and when it originated, there was so little terminology to name all of the social terms of health that we not only had to create terminology, we had to create a method by which we create terminology, right? So we've coined this collectively that you all are part of as the gravity terminology curation process. Oh, great. Okay. Oh, Lucy, I'm going to come back to that in a second, right? That's a really, I actually feel like that's the topic of the August implementation affinity meeting. Just FYI, Lucy, finger on the pulse. So the process that we leverage is evidence-based. And so you can see throughout this paper, there are citations and citations and citations. We spend our summer, I should say, primarily Asha and Sarah, or Asha, gleaning literature, right? Because we want to make sure that what we're doing is grounded in the lit. And we then center technical experts in the domains of reference. So it's evidence-based. It's consensus-driven, which means it centers community perspectives and patient perspectives and community taxonomies to ensure pragmatism and open HL7 aligned principles, right? We do this here by consensus. We ensure that it's what's called semantically consistent. So if we're generating into the vast like green space of health information technology, like terminology associated with healthcare, those concepts have often been defined in communities by other taxonomies and other data systems long before HIT got here. So we always try and ensure that we align with, leverage, and support however social care and however communities have been defining things prior to us. The gold example is HUD, right? So long before healthcare got to naming and defining concepts in homelessness, the HUD, Homelessness Management Information System, had been doing it for decades, right? Or long before we leaned in to try to define food insecurity, USDA had been doing that, right? Or the 211 LA taxonomy, which now has a new name, like that's been in existence for helping people navigate to resources forever. So we don't want to supplant that, right? Anyway, so that's what semantically consistent means. And then we are principled, so we're grounded in the ethics of data justice and social justice as we do this work, just to ensure that that's part of being evidence-based, honestly, when we're addressing the social determinants of health. And then we have these formal 6-month cycles. So pre-work is what we just completed. Like we are not meeting, we're in the background, we're submitting to terminologies, and we're gleaning literature, evidence, gathering subject matter experts for the work to come. What we'll do together over the course of a couple months is identify concepts in community and consensus. And then there's a very locked down kind of formal end-to-end review, and that's part of the robustness of our process. And then we vote, right? And then the whole process repeats itself, right? So Gravity analyzes gaps, we submit terminology concepts to stewards, and then it's repeat in another 6 months. So this is the Gravity terminology curation process. Someday we'll write a paper on it. Asha, Sarah, Susan, community members, whoever wants to come and join, because it really is an outgrowth of the call to arms of what created Gravity in 2017. Like the 2017 meeting identified a need to have a process to develop terminology to address the social determinants of health. This process is the answer to that call, and it was a JAMIA paper. So someday we'll do that in all of our free time. Next slide. So the questions we ask ourselves to do this work are, what are the standard instruments used to identify the domain? And I just want to unpack that for these community level domains, it's not just about instruments, it's also about available data sources, right? So we think about things like the USDA, United States Department of Agriculture Food Atlas, right? That's not an instrument, but it is a freely available resource to understand the food availability in the communities that we live in, right? So for the community domains, it's not just about instruments, it's also about data points, and that's going to be fun to explore. We then ask ourselves, what are the core diagnoses or findings that need to be named, right? And so like lives in a community with adequate neighborhood safety. I have no idea. Like, well, these are the concepts that we'll come up with, align with the literature. And we think about the person and community centered goals. We just we need to change our slide a bit. And then we think about the things that we, the care team and the person and the community do. to address the risk or condition. So next time we come around, we'll change these to make sure we have the community concepts throughout. Next slide. This looks then blooms into the terminology, actually, so next, into the terminology you see here. We've been talking about terminologies. LOINC, you see that in the question. LOINC is a many-faceted terminology, but it does everything from like documents to instruments to labs, right? So you can see the instrument here in one of the questions from the hunger vital sign. Our diagnoses get encoded in SNOMED CT and ICD-10-CM. You can, and as I mentioned, I'm going to the ICD-10-CM Coordination and Maintenance Committee on the 9th, I think. We have our goals, concepts, and then we have all of our interventions, right? So Lucy was asking about billing and payers, adoption of gravity standards, right? You can see actually in guidance utilization of any existing HCPCS or CPT concept, right? We know that payers are having to utilize terminology such as gravity to support things like waivers, right? That's what the New York waiver is a driver of, right? So we have all of these interventions that we create with evidence-based interventions and programs. Next slide. And then the final accessible, usable, helpful end product are our value sets curated by the amazing Sarah Bahal and Susan Matney. And those value sets are freely available for use, right? So we have way over 240 now. I think we have too many to count. So there's both social determinants of health level sets. So every single domain we've addressed has its own collections of codes and concepts. And then there's also the meta ones that include every single concept we've ever named. All of these can be accessed through the Gravity Confluence, and Gravity is the steward, and you can find them in the National Library of Medicine Value Set Authority Center as well. And again, these are helpful because population health entities download these to understand the concepts they want to use to analyze and care for their population. Health records download them in order to update their health records with the most up-to-date, United States core data for interoperability aligned terminologies. Clinical entities use our program concepts to develop clinical decision support, right? So there's all kinds of uses for those value sets because what we create here together, those consensus, everything that matters about food insecurity can be pulled into all kinds of different purposes. Oh, and research, right? We have tons of researchers now who are using our terminologies to drive research because there weren't concepts for what they were studying before, and there finally are. Not yet, Lucy. That's more to come on that. That we're having a meeting after a maternity leave of a key friend. All right, next slide. All right, so here we go. So we're going to kick off into the domains. That was a lot of level setting. It's just the requirement of kicking off. We will not do the gravity overview again. Thank you for your patience. Anyone who's been around, I hope it was fun to revisit. And for anyone who's new, welcome to the work. Okay, fall 2025 domains, level setting from person to population, community level domains, and gravity. Next slide. I'm going to just read this because it's really important. And I'm going to level set with a story. For those of you who know me know this. Oh, I'm so glad. Welcome, Nick. So my first introduction really into quality within healthcare was I was elected the lead of my health service area's accountable community for health, right? So I was a farmer for 15 years, a professor of farming. I had led, and participated in a community development corporation that was building community gardens and supportive housing in the Montana city where I was a farmer. And so I had all of that community organizing history. And so when I came into a role as a rural primary care provider, the hospital that I worked for was like, hi, you have the skills we need to lead our accountable community for health. Right. So it was an amazing lesson for 8 years of sitting around the table with all of the individuals needed to respond to the mandate to focus on community level concepts. And so that drives my personal why of why these things matter. I know they matter because I had the opportunity of sitting with the amazing individuals in a very rural county in Vermont for 8 years as we collectively tried to move the dial within value-based care, and knowing we had to invest in community to do that. So the role of community health in facilitating sustainable health outcomes is long established in the literature and supported by efforts in value-based care. Very simply stated, person-level interventions alone are simply not enough to get to the health outcomes we collectively seek. Oh, thank you, Janice, you're great. And this is just when people ask the community level domains, like that's not within healthcare scope. It absolutely is. So assessing community needs and assets is written into healthcare reg, right? Conducting a formal and collaborative community health needs assessments required of nonprofit hospitals every 3 years as part of the U.S. Patient Protection and Affordability Care Act, right? We do this, right? We think about, and the guidelines to how to conduct a adequate and sufficient community health needs assessment are very, very clear. Community health, community level concepts in core social domains like food, housing, transportation. We've been planning for these since our inception in 2019. If there were very clear boundaries between a household or person level domain and a community level domain, we carved it out, right? And we said, we'll address that one in the future. That happened very clearly in food insecurity. And I see Elham, I see you on the call. So Elham, who's back with us as a subject matter expert, submitted community level assessment instruments to the food insecurity domain in 2019. And we said, not now, but someday, right? So availability of farmers markets and groceries and sufficient nutritious food in the community. So we've been planning for these since our inception. And it's just our honor to address these concepts in our work this session. There are many more concepts we are not addressing that are community level. These 3 are the ones that we're addressing this fall. Next slide. We did send these out in advance, but we just want to make sure that everyone can, if you want to, that you have the opportunity to ground yourself in the extensive literature about the intersection of built environment and health, and community planning and health, and community needs and health. And so you'll find many lovely resources. These are kind of like all over the 3 domains, as I mentioned. But we do have these white papers. Again, you don't have to go through a firewall for these. They're publicly available. They paint I should say broad picture, not board picture. My apologies, that typo is mine. Of how communities identify community needs and transform the built environment towards health and health equity. You can see urban institutes in here. You can see, EPA documents, there's CDC documents. There's all kinds of robust documents about how we get toward community health as a concept. Next slide. So we are kicking off today. Again, let me just see here. Oh, thank you, Corey. You're reading. Thanks, buddy. He's answering your question more in depth, Lucy. So we're kicking off today. We meet every other week through just before the Thanksgiving holiday. So we spend 2 months about in that identification phase, thinking about what we need to say. And then we spend about 6 weeks in that fine-tuning end-to-end review phase. And then we have our final vote on November 20th. All of you will see this in the homework, but please, if you have any local instruments that are used to assess these domains, please send them. Any materials, we want to center them. Any literature on critical programs your community has initiated in order to address these domains, please send them our way. And that's what the submit concepts is. Thank you so much, Sarah B. And thanks, Corey, for doing that. All right, next slide. Any questions? All right, next slide. Now we're going to go into, we have about 45 minutes left in the call. Asha, I think we're doing good on time, my friend. I'm going to just go into food access. Asha's going to cover neighborhood safety and access to green space. We're going to have a high level kind of reflection, and then we'll go to the homework. Again, any SME who's on the call, please pipe in. This is an optional call for you all, but we welcome your expertise. Next slide. And again, throughout this kickoff, you're going to see all kinds of literature and citations. They're all going to be on the Confluence eventually. So much fun to read. Thank you, Asha, for the curating. And then I had a mad dash of additions at the end there. So how we got here with food access, I mentioned this briefly when I told the story about community level food access and food insecurity. So it's in 2019, we addressed Jillian, very funny. In 2019, we addressed the United States Department of Agriculture, USDA, defined broad concept of household food insecurity, which is defined as uncertain, limited, or unstable access to food that's adequate in quantity and nutritional quality, safe and acquired in socially acceptable ways. We put in the culturally acceptable, which was built off the emerging work of Dr. Coates from Tufts. I mean, culturally acceptable is now integrated into most definitions of food insecurity. It was not part of the seminal Bickel Nord et al. USDA funded study for food insecurity, but it is a fundamental part of how we think about food insecurity and food access in 2025 and beyond. To ground that work, and you can see that's a very high level concept, right? Food insecurity is pretty broad. But in order to perform that work with food insecurity specifically, we had to bind ourselves within an operational definition, which means a definition for purposes of the United States Department of Agriculture Food Security Module. So that module measures and defines food insecurity as driven by household financial limitations. So even though food insecurity broadly has all these access components that you know could be associated with whether or not there's actually a market in your community, right? Food insecurity for the USDA is measured by the USDA module, which binds it to household financial limitations. So for our work in food insecurity, that's what we bound it to. And that was my kickoff in Gravity, was I was a former farmer food insecurity specialist. So that allowed us to align with the health outcomes of research for food insecurity, align with the USDA methodology. Everything you see in the lit regarding food insecurity and health outcomes and associations is bound in that USDA method. But it did leave both non-economic and community level concepts of comprehensive food and nutrition security for later work, right? So this is what gets us to food access. Next slide. And just some history, again, we've been doing this for 6 years, so we've touched upon things in previous domains, right? So we addressed food insecurity in 2019. In 2020, we covered how transportation insecurity affects food access, and we crafted the following concept and aligned transportation-specific interventions. Transportation insecurity limiting access to food. You can see the intersection of transportation insecurity and food access in the USDA Food Atlas, right? So when the USDA measures food access, transportation and availability of transportation is a part of that, especially when we think about rural communities, right? Or public, transportation and access in urban communities, right? So we built this concept because our transportation SMEs said this is important to address here. So that's been pulled to light already. This spring, we covered racism and how systemic racism, ethnic and racial discrimination affect food access and food security. And our SMEs and you all identified the following concept: systemic racism negatively affecting food security, right? So that concept intersects with how structural policies determine food access in neighborhoods, right? And so that's not a complete representation of the concept of food access, but it's something we already pulled to light. So in this work, and again, so we'll make sure we go deeper and look at it from all the prismatic angles. But in this work this fall, we're going to lean into aspects of access and availability that remain, including, and reanalyze anything we need to reanalyze, which includes the lack of affordable nutritious foods in the environment, in your community. And also, if the only food that is present is fast and junk food that inundates healthy alternatives, right? So these are the two things we're leaning in with intention, understanding we've covered weaving correct. Yes. So Lorena, thank you so much for being here. Right. So I pulled the paper Desert in New Orleans called to light this concept. And we'll see if we determine that to be the name we use. But yes, yes, yes. The citations are part of where that concept came from. All right. So does this make sense so far? Okay. Next slide. I'm just trying to make sure I'm not missing anything. Oh, thank you, Lucy. Context. Okay, we try to do a why it matters. I hope it's painfully clear why this matters, but we're going to run through it. There's tons of citations. You can see this is like a dense slide, right? Fundamentally, the availability and affordability of nutritious food is driven by policy. We know this, right? Agricultural policy, poor Asha and Sarah got an earful of how much I love Adam Drewnowski, who is a Washington-based researcher who writes how national U.S. agricultural policy drives low-cost, affordable, ultra-processed foods falsely to make those foods more affordable than whole foods in local communities. Big fan, Adam, out there, right? So availability and affordability of nutritious foods is driven by policy, including agricultural policy, community development policy, bias-driven policy, right? All of these things affect what we have in our communities. And you can see there's 3 different citations there. The availability and affordability of nutritious foods is associated with diet quality, of course, and thus rates of diet-sensitive conditions. And I'm going to say diet-sensitive conditions in the literature and food access is so more vast than you think. Like one of the things I was looking into was cognitive dementia in food associated with food access in urban communities. It's vast and significant. The lack, and this is where there's some intersections. Of course, if food insecurity, household food insecurity is defined as that driven by household financial resources, and SMEs, if you're on, please pipe in. If that's what we define food insecurity as, it's very clear that the lack of affordable food in communities systemically drives household food insecurity. Because if the community does not have affordable food, rates of household food insecurity are higher, right? If all you have is high cost, unaffordable options, that affects the rates of food insecurity as reported by the person in the household, right? Okay. Lastly, hi, Janice.
I just want to mention, that is so important what you just mentioned. And, working at the level I do with different people and like measurement and whatever from around the nation, I really, even though it doesn't sound like it, but sometimes, I mean, they don't call it out exactly, but sometimes it sort of alludes, it's, the patient's problem, what they eat, but they really have no idea how hard it is to live on, SNAP money and rely on food banks. And the cost to feed a family, just one person alone, is so much more expensive now. And it's just, I don't know, we can talk till we're blue in the face about it, but it's a very real situation that is one reason, individuals have, some of the, whatever, I guess you say, the diseases that are societal, like diabetes and other things, not all diabetes, but some high blood pressure because of the diet, that they're unable to maintain a better diet. Affordable.
Thank you. Love it. Janice is one of our amazing patient representatives and always brings really salient, pressing, important perceptions. Thank you, Janice. And I just want to highlight what you said. So I in rural medicine where I practice, sometimes the closest food is like the Dollar General, and that's not good food at all. Right? Yeah. So in my FQ that I work for actually has an initiative to start and sustain groceries in its health service area, because if the grocery disappears, they know it affects rates. So heard and yes and thank you.
Yeah, I want to add to that I was outside of Pittsburgh a couple years ago, and it really indicated how people, what they want ends up in the grocery store. there was literally a whole long row of soda pop, and I couldn't even find club soda that I like, right? And it was just sugar drinks. And another thing is, like, in the Ninth Ward, there's only one store, and I forget his name, but I've watched him since after Katrina, who sells fresh fruit. And
Thank
yep.
you.
And so
Yeah.
it's just a very real situation.
So this is why we're talking about both concepts, right? Not just is the healthy food available, but is it as available as unhealthy options, right? It's really important. So thank you so much. And you can see all the SMEs and friends are putting in names for these concepts. We're notably not using the term food desert right now because of USDA and some of the ecosystems shift away from that concept. We will center it with our SMEs and we will come back. All right. So lastly, and importantly, so it's not just about those obvious. Yes, Lucy?
Yeah, Sarah, I just wanted to mention that some providers, which I'm sure include you and your clinic, have known for a long time about food insecurity. And I don't know if anybody remotely related to Kaiser is on this call,
Oh,
but
yeah.
Kaiser started having a food market
Hmm.
in its hospitals
Hmm.
like decades ago. So the responsibility for doing something about
Hmm.
community food access, I don't
Hmm.
know whether that's really on our agenda for
Oh,
us
this
to
is it.
say
We have.
who's res
Yeah.
okay, who's responsible for responding
Mhm.
on this subject. I just wanted to bring Kaiser up because they're just such a stellar example of this and for such a long time.
Thank you. We Kaiser's a dear member, as you know, and we talked very closely about whether or not they needed or could send a SME to the work. Um, they kind of did a "you're in good hands" thing, but we're very close and connected to Kaiser. And I just want to note some of our resources in the food access work are actually toolkits for how to develop healthy food resources in your community and how to figure out who's lead. So many of the questions, Lucy, you raise are in some of our resources, and just yes to Kaiser. Huge fan. Patricia?
I was also going to say, 'cause I'm going there tomorrow, Langone Health, NYU,
Oh
has a
yeah. Mhm.
wonderful example program. And as a social worker, I'm not only interested in seeing that we have access to these programs, but they're delivered in a very dignified manner. So they
Mhm.
have set up
Mhm.
their programs to their family health centers as a grocery store.
Yeah.
So, you're able to actually go, people who are in need, families that are in need are able to actually shop as if it actually is a grocery store, which I think is a wonderful way to deliver these kind of programs rather than just handing them out. So, and if you need more resources, I'm actually working with someone on a paper on best practices around how do you set up these kind of programs.
Okay.
Be in the community. We're also looking at college level programs,
Okay.
food pantries and stuff like that. So I'm happy to share those resources as we've been developing those the last few months.
Thank you. Love
Patricia,
it.
I hope you're counseling your future mayor about how to do what he wants to do. Free groceries
Well,
in New York.
I don't live in New York,
Oh, okay.
but I spent a lot of time in New York. And yes. I mean, I
Make
think
sure you're not more than 1 or 2 degrees away from him. So make sure he knows that people know how to do this.
yes. We're hoping to not only affect New York, right, but other states as well. So
Thank
New
you,
York
Patricia.
starts to do it, other people are going to follow.
it's good point. Yes.
Thank you. And then Corey, you have a thought before we go on?
Yes, sir. This may be tangential and you can just put it in the parking lot if it's, but as I look at these community concepts, I'm asking myself sort of where does this community level food access in this case get documented? How do we,
Mhm.
I'm thinking, because, I'm thinking from a exchange perspective and how we, like, I don't know if I document in a clinical chart with, or even a social care longitudinal record that the community has food access problems and an individual's record. And if that's beyond the scope of this conversation, we can talk about it another time.
It already is getting documented, but just in free text, right? So like if I'm trying to like if I'm working with a patient who has diabetes, right? Oh, and Lorraine is all ready to come in with her Maryland example. But these kinds of things are already getting documented because I can't make treatment plans to diet sensitive conditions without understanding where they live and whether they have access to nutritious foods, right? So these things are getting documented in a lives in or has limited access to way, right, already in a person's chart in order. And there's certainly, yeah, I don't know if that, I hope that's not
Yeah, it
tangential.
does. I mean, it's a stupid question. Maybe this one is more about the individual. Maybe I'm seeing community and thinking more about this as a community finding.
It
But
is
what
a
you're
community
talking,
finding too in the like a community health needs assessment. Like, so I don't know if you like, so that's, it gets documented in both ways. As a community, if you live in a catchment area of a nonprofit hospital, the CHNA is there as the healthcare's accountability to all of the findings of that assessment. Again, we're going to explore this
okay,
together. Fun
yeah,
times.
thank you. I'll think on that some more. Thank you so much.
Okay. And then Lorena, before we go on, do you want to offer some wisdom because you have a really fun use case and example?
Yeah, so I mean, we've actually created a social care chart, basically. So we've actually divided, as an MCO, we've divided up our team. So our care managers actually really just focus on managing chronic diseases, and we've got a whole team of social workers, community health workers, and we've actually divided Maryland into 5 different regions. We've designed a social risk score that we just got, we got an NIH grant for, which we had an NIH grant, it was taken away, now it's back again. So, hopefully, we're billing as much money as we can now to it. We're partnered with University of Maryland, Baltimore City, or Baltimore County, for development of that. But we're actually actively charting all of that. We've actually mapped loin codes on the back end to our screener to be able to now track everything all the way through. So, and that's actually how we designed a food delivery program that's county by county and did it in collaboration with community-based organizations. And we've already seen a huge improvement where 75% of the people that we identify in Western Maryland that have food needs are now getting resources, and 38% of them are no longer food insecure after 3 months. So we're really impacting based on all the data that we've been able to aggregate. Sorry, Sarah, I didn't mean to go off on a tangent there, but we did
No, it's
extensive
great.
work
It's
on
why you're
this.
here. And even, but part of why, again, thinking about the difference between food insecurity and community food access,
Mhm.
your connections are not just at the person level too. The part of why Lorraine is here is because she builds hydroponic lettuce factories and employs individuals who need work in those factories to make food more accessible in communities. I hope that's okay, right? You do it.
No, it was we did it school-based
Yeah,
with the
yeah, there we go.
hydroponics, and they're actually supplementing the pantries.
Yeah.
And then what we've done is, because as an MCO, we're actually reimbursing the community-based organizations, not because we have a waiver, but because we're reducing medical costs. We actually did a different study and showed a 13% reduction in Medicaid, the medical loss ratio for Medicaid. But that's actually how we afford to pay the community organization, and that's actually created jobs for the community organizations to be able to pay local people in order to do it. We're also sourcing all the food locally, so it's
Awesome.
actually helping the community as well.
Thank you so much. So rad. It's so rad what Lorena's doing is so rad. And then Corey, like I think I saw you continue to, this is what we need to, like that's part of what we need to work on together, friend.
Yes, yes,
Right. So that's partly why community level domains are at the topic that I want to talk about, the working group meeting.
yes.
Right? Because it's happening. We know communities are doing this, but where and how in a standards-based method? Interesting, right? And so that, yes, fun times. Yeah, and the thing is that this is a true instance where like when we're talking about household level concepts, it's difficult to say, to really build in and pull forward that, the kind of the zip code level analyses. But these kinds of statements, like my neighborhood does not have enough access to green space, are something you can say about a region before you've even assessed it for the person, right, Corey? It's true. It's in the community, right? We know this, right? And so it becomes a healthcare concern for the person when we see it affecting things like their physical activity goals, right? No, Sarah, I can't walk. I don't have a gym. I don't have a working sidewalk. I don't feel safe when I go outside, right? But I know those things in some sense from community level findings and community level data. CDC has been researching these concepts for years, like decades and decades. So that's going to be really fun. We're going to figure it out. Sound good?
Great.
All right. I have to make sure I give Asha time. We're doing okay. We still have a half hour. But lastly, I just want to note that even as we talk about these conditions, right? And I just mentioned one, like, it's not even a condition, but a goal, like, please get your steps in to support your hypertension goals, friend. And they say, nice try, Sarah. I can't do that because I cannot walk in my community, right? So that's all clearly in the third bullet. But we also know very clearly regarding food access, specifically the community food access, including agriculture. And this is like my origin story is I was an organic farmer and I grew up on a farm, right? And I farmed for 15 years. So it was like a huge part of my life. Community food access, including agriculture, is a social and cultural requirement. So community food access moderates the negative mental health effects of household food insecurity, right? It is a critical facet in fostering social connection. There's a beautiful brief by our friends from the Foundation of Social Connection, who are all experts in our social connection domain. And we know that it's a critical facet of connecting to your culture. Like there's really amazing studies about acculturation to food and cultural identity in new American populations. There's lots of research on that. We know there's a lot of investment in indigenous food sovereignty as a means of having food sovereignty and cultural food access super connected to mental health, physical health, and indigenous identity. There's two USDA citations there for reference in the U.S. Food Sovereignty Alliance. So just noting that in addition to the, diet sensitive conditions and food insecurity rates, these like social and cultural components are really critical. You will see social connection and cultural components woven throughout our three domains, and we're going to have a final reflection on that before we go into the homework section. So we would be remiss if we didn't note this as well. All right. Okay, now I think, Asha, my friend, next slide.
Yes.
I am passing the mic to my amazing colleague and friend, Asha Emanuel, to help walk us through concepts in neighborhood safety and access to green space. Kick it away, friend.
Thank you, Sarah. Well, good afternoon, Gravity family. Let's talk neighborhood safety. Okay, so I want to take a moment and ground us in what we mean by neighborhood safety, because it's really the foundation. It is a foundation for health and well-being. As a community health nurse specialist who both lives and works in my neighborhood, I see every day how neighborhood safety, or the lack of it, shapes our lives. It affects whether we feel comfortable walking to the corner store, letting our kids play outside, or simply getting a good night's rest. Neighborhood safety isn't just the absence of crime. It's more than that. It's a community level condition, something that touches every part of how people live, move, rest, and thrive. And the literature recognizes that neighborhood safety includes two interconnected parts. One is objective safety. This is the visible, measurable factors like crime rates, traffic collisions, and physical neglect. And the other is perceived safety. This is how safe we feel in our neighborhoods, in our streets, and with our neighbors. Both matter, both impact health, and both must be named and addressed if we want our communities to truly be places of well-being. So neighborhood safety isn't just one thing. These are some key concepts when we think about neighborhood safety. It's an ecosystem of conditions that either support or undermine well-being. First, there's the built environment, and Sarah has talked about the built environment and how it's all throughout these three domains: sidewalks, lighting, housing quality, roads. When they're broken or poorly lit, they send a message of neglect, and that restricts physical activity. But when spaces are clean and kept well, they invite us to walk, gather, and feel connected, and that's safety too. Then there's the social environment: trust, shared norms, community connection. And when neighbors know each other, when people look out for one another, crime goes down and well-being goes up. So social cohesion and what we call collective efficacy, that shared belief that together we can solve problems, are powerful protective factors, right? And then we go on to neighborhood disorder. That's another layer of neighborhood safety. Things like graffiti, abandoned buildings, in constant noise, even when without high crime rates, those cues can make folks feel unsafe and keep folks indoors. Finally, we can't ignore the economic and social disadvantage that's present. Disinvestment, poverty, and systemic neglect make some neighborhoods far more vulnerable than others. These layers, the built, the social, the visible, and systemic layers, interact to shape how safety is experienced itself. And if we want to address health disparities, we have to take them all seriously, all of these components. So, how does neighborhood safety matter? Why does it matter? So let's start with mental and emotional health. Living in an unsafe environment can change your nervous system. It raises anxiety, depression, PTSD, and toxic stress. Even hearing sirens or worrying about your child's safety can disrupt sleep and lower your sense of well-being. So now let's look at physical health. When folks don't feel safe, they stay inside. That reduces physical activity, it increases chronic disease, and can even worsen birth outcomes. Unsafe areas are linked to higher BMIs, even in kids, and neighborhood disorder is tied to lower use of preventative care and higher emergency room visits. But here's the key: perception really matters just as much as the objective crime data. If we feel unsafe, we change our behavior and we shrink our lives. But when we feel safe, we open up, we move more, we engage more, and we trust more. And that's why neighborhood safety isn't just a symptom, it's a vital sign, really. It's a foundation for health equity and thriving in general. So I'll stop there. Are there any questions about neighborhood safety, the level set of it, and why it matters?
Asha, one of our amazing subject matter experts, has dropped a couple of resources into the chat. Our friends at Prevention Institute. Rachel is with us. So Rachel, I just asked you a question. If you could just answer in the chat, do you want to take the mic for a second, or do you want us to just bring those resources back? We're happy to center you. And for those of you who don't know, Prevention Institute is one of my favorites in the whole world. What would you like to do, Rachel? Do you want to just bring these back later?
My camera's not working. I'm happy to bring them back later. I know we're like a little low on time, but I appreciated this broad conceptualization. And we've worked on a lot of ways to try to connect them all together as, you know, part of a cycle that I think really leads to inequitable outcomes and whether or not people are safe. So I'm happy to share more as part of the work group.
Great. And then maybe what we love doing is centering SME expertise specifically and having them lead like a presentation and help educate all of us. And maybe we can do that in the next meeting.
Or a future meeting. Yes. I'm happy.
Sounds like a plan. Lucy?
Yeah, thank you, Asha. Everything on this slide has entered politics, at least where I live. And so our conversation about this from our healthcare, social care, social welfare, public health point of view is going to be an alternative to having more police to fix all this.
Mhm.
Which is a very popular political solution right now. So I just want to put that in the conversation so we all realize that what we're doing is discussing an alternative to more police. I also wanted to ask about this very last dash, improving how safe people feel. One of the things that I've observed is once this becomes a political issue, it becomes a political asset for some people to ensure that people continue to feel awful and unsafe. And therefore, intervening to change how people feel could potentially be a huge frontier for us to be thinking about. So I hope that we will. Thank you.
Thank
I
you,
mean,
Lucy.
stoking fear, we all know this.
Yeah.
Stoking fear is a basic political strategy. And as long as you stoke fear, people are going to feel, they're not going to feel good.
Mhm.
Lucy, thank you. And I want to note you're going to see a friend concept that you care about deeply at the closing section. I think it's salient for you. And I just want to note the resources that Rachel put in from the Prevention Institute are powerful examples of affecting change collaboratively, thoughtfully, sensitively, sorry, it's making me emotional. Like with trauma in mind. So Prevention Institute really leads the way with much of the like really best practices in this space. So we're very grateful. And so the resources that Rachel put in there from the Prevention Institute are right in line with what you're saying.
Wonderful. I know.
All right, Asha, you take it away, friend.
All right. So then we'll move on now to access to green space. Right. All right. So access to green space, it might sound like a luxury, but it's actually essential to health. When we say public green space, as it's listed here, it's referred to that in literature, public green space. We mean parks, trails, gardens, natural areas that are open for everyone and not just for play, although play is important, but for healing, connection, and rest. But having a park doesn't mean having access. So there are some dimensions to access that we want to talk about. There's the physical access, right? Is it close? Can you walk there safely? There's a social access. Do you feel welcome and included in that space? And then there's the ecological quality in terms of access. Is the air clean? Are the trees cared for? Is there a lot of biodiversity there? Is it safe? So, the other key components of this are we talk about health promoting infrastructure, and those are things like trails and benches and lighting and tree canopies. These things don't just make a space look better, right? They support clean air and foster community. We also recognize the role of the built environment and the natural environment in shaping how and whether people use green space, especially in rural and urban environments. And finally, we view all of this through a health equity lens, or I do specifically, and so does the Gravity Project, because green space isn't equitably distributed, right? Neighborhood safety, neighborhood history, race, income, and disability all shape who gets access and who gets left out. And as someone who walks through my neighborhood regularly, I see the difference between a neglected lot and a vibrant shaded park. One deters community, the other builds it. And this is about making sure every person, regardless of their zip code, has access to a space that allows them to breathe, move, and thrive. And I'll stop there. Janice, you have your hand raised.
Yeah, thank you, Aisha. I just really appreciate this presentation. I wanted to mention that in the health promoting infrastructure trails, all this, it's also important that it's accessible to individuals with disabilities, wheelchairs, because, or, walkers, people with canes. It's because often it's not. And so we've tried to do some of that here, but there's actually some really good sites. I think we brought it up once here, but you can look up, like wheelchair access, trails or opportunities in cities, and some don't offer it, but it's very important, I think. And as elder individuals or individuals with mobility concerns, they're even more fearful of perhaps safety, right? Not only like falling or, not necessarily physical. So it's just something to be aware of. So thank you.
No, thank you, Janice. That is a great point. Yes, we need to make sure that the infrastructure is suitable for all to enjoy, right? This is a public green space, and that includes all of the public. So thank you for that comment. Thank you for that comment. All right. So why does it matter? Let's talk about why green space is a public health priority, right? So if we want to talk in terms of physically, the lack of safe green space means less movement, right? Less movement leads to chronic conditions, obesity, heart disease, diabetes, hypertension, cancers, and respiratory illnesses. And neighborhoods with fewer parks often carry heavier burdens of chronic illness. But when green space is accessible, right, we see better outcomes and accessible for all of us, Janice. We see better outcomes, even in terms of healthier pregnancies, which is my heart, making sure that we have the most healthy possible pregnancies and births as possible. Moving into the mental health section, being in nature helps reduce stress and anxiety and depression. It supports healing. It gives the nervous system a place to rest. It's why we have highlighted throughout our domains ecotherapy as an intervention, right? It really does matter. And then in terms of socially, green spaces bring people together. They foster belonging, trust, and safety. They become places where kids can play and elders can rest. And through, with a health equity lens, we see this clearly. Unequal access to green space reflects structural inequalities. Neighborhoods most in need of healing spaces are often the ones with the least shade, the fewest trees, and the most neglect. This is a policy problem. And it's an equity issue, and it's one we can't ignore if we're serious about whole person care. Right? So, any questions about access to green space?
And Rachel put another piece of literature in the chat. Thank you, Rachel. Prevention Institute is just a wealth of resources. Having them focus on one or the other domains is challenging. I want to note that Corey's leaning into some kind of conceptual conversations regarding what we mean by community. And I responded in the chat when I'm responding, so that's a very good question, right? So there are some fundamental framings of how we think about how people relate to built environment that are in some of the literature that we've already put on the Confluence. We define community very vaguely, but comprehensively in our protective factors work. There's horse of the community definitions that are defined by health service area and community health needs assessment, but I promise that we'll lean into it. And it may involve some refining where it's not just like we consider both lives in, works in, in order to unpack the nuances of what kind of the community definitions that you're mentioning, we might need to refine some of our terms a little bit and be more specific, but thank you for bringing that to light. Janice?
Thank you. I just wanted to mention too something. Was fortunate. I lived by a park when I lived in low income housing, and it was a beautiful park. Actually, it was a mansion that low income women lived in. It's kind of a experiment in Seattle. But anyway, the park is nurtured and cared for by the community because the parks themselves don't have a lot of money to do it. For instance, we had like Dutch elm or something, and it cost a lot of money to mitigate that. And they raised money themselves and took care of this situation. And I've been around long enough to see this happen twice. I don't live there now. My comment about is because I'm involved, like with green space here, is we're having a problem with two trees that are too old and they're now buckling the sidewalks. So there's no real process I've seen in this space, no matter where you are, like if it's a park, a green space, where you have to actually kind of plan ahead. This tree is getting older and to replace it early rather, not replace it, but, plant another one, sort of a cyclical planning that doesn't really happen. I haven't seen that anywhere, but it's an important part, it's something to think about.
Mhm.
Janice, Asha and I often talk about the little Valhalla. I live in like Burlington, Vermont, which is the tiniest, most precious, try hard little community. We just did that where we had this like a longitudinal replacement plan for aging trees. And so the urban forester went around years in advance and planted baby trees next to the trees they knew were going to phase out in 5 years. And then suddenly those older trees were cut down, but we knew it was coming. It was it was just like very sweet. But yes, that's very critical. And thank you for elevating that. We're at almost at time. So I'm going to try to pull us down to the next oh, okay.
Yeah.
So again, Corey, a lot of what you're elevating is like there's a lot of that in the lit too. So we promise we're gonna get deep into that. I promise. Okay, next slide. Lucy, I hope you hear your thoughts in this slide. We just wanted to note before we close that we planned for these domains as interconnected by intention, and I think you can probably hear in the what and the why about how they are intertwined, right? So one of the primary, how interventions on one affect another, right? How they're interconnected. Themes through all of these three domains are themes of the critical intersecting role of community, culture, and ecology. It's everywhere, right? Neighborhood safety, green space. Just things that we've addressed in prior domains, just noting that we've talked about social connection in prior domains. We've talked about connectedness to community, connectedness to nature, and then that civic engagement and belonging and civic muscle concept from the vital conditions framework that was so critical within our strengths-based and protective factor work. So just noting that these belonging, connectedness themes that we felt within the literature and the problem statements of these three domains are things that we've seen in our prior work. And just calling that to light. We pulled in the vital conditions framework again. And so I think we're ready to close. Asha, thank you for leading us so elegantly through those domains. Next steps. Thank you for coming to the kickoff. We have lots of really amazing work to do together over the course of our months. So there is a lot of material on the Confluence to read about. Beautiful high-level papers and concepts. And so read if you want to, if you have time. We're going to gather our subject matter experts and come back with centering their wisdom even more in 2 weeks, right? And so thank you. And we're going to make sure every single one of the resources that I think some of them are already in our resources, but just, yeah. And then submit concepts if you have them, review the food access, neighborhood safety, and access to green space pages, and then come back. And then we'll see.
Sarah, notice what Patricia is volunteering.
Oh, yes. Yes. I mean, yes, sure. That sounds great.
I didn't know what's been done, but we integrated aspects of this and other social determinants of health. We built it into ICD-11.
Correct.
It's not perfect, but what we're
Yeah.
looking for is, and why I'm here is also to see from groups like this, what needs to be changed as we update ICD-11, and then also the environmental sections, which was built over 25
Yeah.
years ago in ICF.
Yeah.
So yeah, but I'm happy to kind of just real quickly just jot them down side by side in a table, and I can send them to you.
That sounds great.
Yep.
And part of the reason why I paused, Patricia, is because Sue Bowman.
Yep, Sue's here. I know we've been chatting chatting.
I know.
Yeah,
So
yes, I know,
Sue-
Patricia.
Yeah, so Sue is leading kind of an analysis of Gravity's thoughts on updates to ICD-11.
Okay, so Sue, you and I will touch base then.
Yes,
Oh,
sounds
I'm
good.
like,
Good.
right?
Because
That's why
I like, Sue, I have the Passio project going into the annual WHOFIC report due in September 1st. So maybe we can also pull in Gravity. Let's pull it in for
Sure.
WHO and present it in Geneva.
Woo,
Okay,
Sounds good.
sounds good. Okay, we'll talk.
Yes.
Next.
Presented in Geneva.
Yeah,
Boy, Gravity is really, really reaching out. Thank you, Patricia. And be sure to initiate.
Sue's going to be part of this.
Sue is part of it.
Yes.
And just, Patricia, just for your awareness, I know we're at time. Just FYI, I just reached out to Michael Marmot because he and I had a conversation 7 years ago, and he was like, go first in US and ICD-10 and then come back. And I'm like, Michael, I'm coming back.
That's great. Please do.
Like, you thought I would. Okay. Anyway, thank you all. We will see you in 2 weeks. We appreciate all of you. And thank you, Smeeze, for piping in. And we'll see you in a bit.
Thanks, everyone.
Thanks,
Thank you,
everyone.
everyone. Bye.
Thank you. Bye-bye.